Thank you, Madam. And I thank the organizers for giving me this opportunity to talk on a topic which is a hot topic nowadays, that is the maintenance therapy. As all of you know, that the mainstay of treatment in carcinoma ovary is surgery and chemotherapy. Lately, you had the targeted drugs, but now you have immunotherapy and you have the state-of-the-art PARP inhibitors which are there, which come into the treatment paradigms. So why is the PARP inhibitor more important? Because if you see, you give chemotherapy or you add the biologicals with it, you are just looking at 1 to 1.5 years. So invariably, whether you give chemo or you give chemo plus targeted therapy, invariably you find that about 70% of ladies relapse within the first 3 years of treatment. And if you look at the 5-year overall survival, it is a dismal 35 to 38%. So there's a significant need for better frontline treatment to improve the outcomes for women with ovarian cancer. Another fact is that when you look at the first line, second line, third line, now we have a plethora of choices for the treatment. What is happening is there is a shrinkage when you go from the first line to the second line, third line, fourth line, fifth line. So from about 28 months of median progression-free survival, you're just having a 4-month progression-free survival. So the accent here is to stretch the first line treatment or to give a maintenance so that this gets stretched and you have the sensitive clones still which are there in the body which might respond to the subsequent treatments. So is there any strategy by which you can stretch this? Because when you see the survival, you find that this graph keeps on dipping as the time goes. So that is the reason why we choose for certain strategies by which we can embark on stretching this first line. And how is it done? This is either you give the conventional platinum doublet, which is paclitaxel and platinums. It can be carboplatin or cisplatin, but generally we are giving paclitaxel and carboplatin. Or what you do is you give a PARP inhibitor maintenance, or what has been conventionally followed now, you give a BEV maintenance. Or the latest is you give a combination of both. So that is what I'm going to delve on. So we'll be focusing on this maintenance, because if we stretch the this period, so that is the only way by which we are going to do justice to the treatment. So the US FDA approved PARP inhibitors in ovarian cancer are, you have a whole gamut. You have olaparib, you have rucaparib, you have niraparib, and then you have talazoparib, and a lot of paribs are coming and joining the bandwagon. So I'll just go through the whole schema. So the schema of my talk will be to see these 4 trials in which olaparib is being used, olaparib plus bevacizumab is being used. That is, you are having a PARP inhibitor and along with that, a combination of a VEGF, whether it is beneficial, or you're using niraparib or you're using rucaparib. So you have 4 main drugs which I would be discussing. So, just to recapitulate, if you talk of the if you make a pie chart as to what is the percentage of patients in ovarian cancer who would come under the ambit of treatment of PARP inhibitors, you have the BRCA1 and BRCA2 mutants. So BRCA1 is the commonest, that conforms to about 15% of all the mutations. BRCA2, you add another 5%, so you have about 15 to 20% patients who are BRCA mutant. So this was the thought process which was there about 5 years back. Now we know that there is another subset which is the HRD, that is the homologous recombinant deficient cancer patients. Now these patients, they conform to yet another 30%. So you have the BRCA group and you have the HRD group. So if you talk of patients who can come under the ambit of treatment for PARP inhibitors, it is about 20 plus 30, that is about 50%. So with these PARP inhibitors, you can target 50% of the patients in the maintenance, whether it is the first line maintenance or it is the second line maintenance. So to make life simple, solo trial is in those patients in first line maintenance who are BRCA mutated. So those patients who have BRCA mutations, that is, who conform to those 15 to 20% of cases who are BRCA1 or BRCA2 positive, these are the ones in which olaparib was pitted against placebo. This was about 5 years back. Then came the HRD, that is the homologous recombinant deficient group. So the question was whether you can add bevacizumab to those patients who have been given only PARP inhibitors. That was addressed in this trial. This is the Paola trial, in which olaparib was added with bev. And they found out the patients who had the best response, they were not the BRCA mutated, or they were not the BRCA plus HRD mutated. They were the ones who were HRD mutated patients. So it is not necessary that PARP inhibitors will work only in patients who are BRCA mutated. Patients who have HRD mutations, these patients come under the ambit of this trial. And it was found that the addition of bevacizumab to olaparib, it augmented, that is the VEGF augmented the action of the PARP inhibitors. So it was a double whammy for the cancers, and that way it proved benefit. The third one is that you have the BRCA mutated, which is solo. You have the BRCA and the HRD mutated. So there is a group which is not HRD, it is HRP, that is homologous recombinant proficient, who don't have these deleterious genes. So in that group, the niraparib drug was pitted against all the others. So in all comers, it was tried whether it is beneficial or not. So it was found out that in patients who were BRCA positive, they had the best response. In the patients who had HRD positivity, they had a slightly lesser response. And in some group of patients who were HRP, that is homologous recombinant proficient, even they had about a few months of survival benefit. So these two drugs, that is niraparib and rucaparib, these were given in all comers. So rucaparib was given in the Athena mono trial. It was given in all patients who had completed chemotherapy as first line to see whether they benefit or not. So this is the basic skeleton of my talk here. And now we can just quickly go through the trials. So I'll just repeat again. You have BRCA mutated, you have HRD. BRCA is only conforming to about 15 to 20% of the whole gamut of mutations which are seen in ovarian cancer. You see the HRD group, you add another 30%. So BRCA plus HRD is about 50% of patients whom you can target. Patients who have BRCA mutations, you can give olaparib or rucaparib or niraparib. You can give all of these because the onco driver is BRCA. So you can target the PARP inhibitors. Patients who are BRCA negative and HRD positive, in this, again, you can give olaparib and bev. This is the Paola trial. And patients who are all comers, that is, who are either BRCA mutated or non-mutated, HRD deficient or non-deficient, in that you can add Prima or the Athena mono. So this is the first trial which I was talking about, in which it was newly diagnosed patient with stage 3 or 4 high-grade serous or endometrioid ovarian cancer. And they had undergone cytoreductive surgery, and they had either a complete response or a partial response. Mind you, patient who has a progression of disease, they cannot be taken up in the maintenance arm. So you have patients who had germline, somatic, or BRCA mutations. So this was the only subset which was there in solo trial. and they were given olaparib 300 milligrams BID versus placebo. This was a 2:1 randomization, and patient who had a complete response after 2 years, the drug was stopped. So the time limit is 2 years, or you can go on till the disease progression, or if there's any intolerance. So the primary endpoints here were progression-free survival, and the secondary endpoints were overall survival in this trial. And you find that the progression-free survival is maintained over a period of 5 years. So this is something very heartening. So what I was telling you was that, say, after first set of chemotherapy, if you can prolong the time period, that is the thing which is going to give you an actuarial survival benefit, not that you keep on jumping from one chemo to the other, to the other, to the other. So if a patient has BRCA mutation, that patient is going to have the best response. If the patient is HRD, that patient will have a slightly lesser response to PARP inhibitors. Some patients with HRP, those who don't have BRCA also and don't have HRD, they are the ones also who might come under the ambit of PARP inhibitors. So here you find that patients who were put on PARP inhibitors who are BRCA mutated, even after 5 years, 50% of patients are alive, which is something very profound, which was unthinkable earlier. So the PFS is about 48% are alive after 60 months. And, after these 7 years, you find that if you compare to the placebo, again, you have the median overall survival, which has not been reached. So such a, stark difference is there between the placebo and those patients who were given this drug. So this was the outcome. The maintenance led to a substantial unprecedented improvement in PFS. Unprecedented means you have patients who have the BRCA mutations, which are about 20% of all ovarian cancers, subjected to treatment, and you find that 50% are alive after 5 years, something which was unheard of. So that gave the clearance to this drug. And now we go to the next trial, in which you have again high-grade ovarian and serous endometrioid cancer patients who have undergone surgery, who are platinum and taxane-based surgery post that, and they might have 3 cycles of bevacizumab. So now the obvious question is, which are the patients whom you give bevacizumab? Bevacizumab you give to high-risk patients. High-risk ovarian cancer patients are the ones who are either stage 3 or who are stage 4. They are those patients in which the cytoreductive surgery has not been proper. They are those patients who have pleural effusions, who have polyserositis. And they were the ones who could be given bevacizumab along with conventional chemotherapy. Now the question arises, you continue bevacizumab after the completion of chemotherapy, you give it for about 2 years, or along with bevacizumab, you add olaparib in those patients who are HRD or BRCA positive. And in this, the primary endpoint was the progression-free survival, and the secondary endpoints were the overall survival and the toxicity indices. And here again, you find that if you see the progression-free survival, it is 22.1 months against 16 months, which is with bevacizumab. So again, I'll reiterate, patients who are BRCA positive, patients who are HRD positive, these are the patients who can be given the benefit of about 8 months, 6 months over and above bevacizumab. So you have a segment which is chemotherapy only. You have a segment which is chemo plus bev. Now you have a third segment in half of the ovarian cancer patients, because I told you BRCA and HRD conform to about 50%. So half of these patients, if you give chemotherapy plus bevacizumab plus olaparib, then you get a benefit of about 6 months over and above bevacizumab. So this was the Paula trial. And again, if you see the HRD positive patients, this was maximum benefit was in those patients who were HRD positive. So olaparib plus bev provided a clinically meaningful improvement in the overall survival also. You can see the 5-year overall survival rate is about 65% versus 48.4%. And here also the hazard ratio is very, very robust, that is 0.62. Here again, I wanted to show you, you have patients who are BRCA mutated. Obviously, they are the ones who will have the best benefit. And the patients who are HRD positive, but BRCA non-mutated. So those patients who are HRD positive, here again, you are going to have a benefit. But unfortunately, the patients who are either BRCA or HRD negative, these are the ones who are not going to have any benefit. So the takeaway message was that this was an active treatment for patients who were either BRCA or HRD and provided a meaningful improvement in the progression-free survival, about 6 months benefit as compared to the others. So the third is the primer trial. So this is again newly diagnosed patients who were given 6 to 9 cycles, and either they had a CR, that is a complete response, or a partial response. Primary endpoint was PFS, and they were given niraparib versus placebo, and this was given for a period of 3 years or progression of disease. And here you find that again in patients who are HRD, you have a significant improvement as compared to the placebo. So in this trial, if you can see the lowermost part, you had 30% patients who were BRCA positive, about 20% patients were HRD positive plus but BRCA negative, and 34% patients were HRP, that is homologous recombinant proficient patients. So it was found that in HRP patients also, there was some improvement as compared to the other patients. So you have BRCA mutations, definitely you find a benefit here. And if you have a BRCA mutation versus BRCA wild type, that is HRD positive, still you have improvement. But this was something which was different in homologous recombinant proficient patients. So I told you 50% patients who were BRCA and HRD, 50% were the otherwise. So even in the otherwise patients, you find that there was a slim advantage of about 1 to 1.5 months. And this is the last trial. This is the Athena mono trial. This is currently undergoing. The data is not yet approved, but one arm has been shown, that is rucaparib. That is the fourth kid on the block. And this also has shown that in all comers or HRD positive, definitely there is an improvement which is seen, as I was explaining you in the last 3 trials. So if you have the BRCA mutation or if you have the HRD positivity, you have a stark improvement. As you can see, the curves are separating here, but you have a slim advantage in those patients who are all comers also. So I think this is the last slide. And so this is the gist of the whole thing which I've told you. So if you follow a patient from the beginning, what you do the somatic and the germline BRCA testing, plus you do the HRD testing. So initially what we used to do was we used to just look for BRCA if you go 5 years back. But now practically, for practical purposes, all patients we are doing HRD. So if you do HRD, you will not miss those 30% patients who are BRCA wild type. So you're checking for the BRCA mutation also, you're checking for the BRCA for the HRD. So by that you're capturing 50% of patients. So these patients you check at inception. Now, why do you check at inception? One, of course, it is prognostic, and secondly, it is predictive also for treatment. So if both of them are there, then it merits testing here. So initial decision should be whether you send these patients for neoadjuvant chemotherapy or you do a primary debulking. Well, if you're given neoadjuvant chemotherapy, if you've done surgery, then the next question would be, do you give bevacizumab or not post-surgery? So as I told you, patients who are high-risk ovarian cancers, these are the ones in which you can add bevacizumab after 3 cycles. And along with chemotherapy, that is paclitaxel and carboplatin, that is the current standard. So patients here, you check for the HRD, subject them to surgery earlier, or you give them chemotherapy. If you give neoadjuvant, then the decision should be for the next 3 cycles, should you add bevacizumab or not? Now you have come here, you have given bevacizumab during chemotherapy and maintenance. So whether you see whether the patient is BRCA mutated or HRD, if it is BRCA mutated or HRD, any one of them, then you can give olaparib plus bevacizumab as a maintenance, which I showed you, showed a 6 months improvement in PFS. If it is HRP, then probably you can try the Athena mono trial in which rucaparib was given, but the final testing of the pudding should be after you get the oral survival benefit. And if you have just given the patient chemotherapy for 6 cycles, you have not added bevacizumab in the anterior treatment, and the patient has not got any bevacizumab, if the patient has BRCA mutation or HRD, then according to the solo trial, you can give olaparib or rucaparib in these patients. And if the patient is HRP, I showed you there's a very slim benefit in the other 50% of patients. There probably you can discuss with the patient and give this patient niraparib, or just keep on observation, or if the patient is a high risk, you give bevacizumab. So I think that was my last slide. I thank you for your patient hearing. Any questions? Yeah. Somebody can give her a mic, please.
Sir, in routine practice, you advise both BRCA1, BRCA2 and HRD, and then give the bevacizumab with olaparib.
So you have a brand new patient. You do the BRCA and HRD. BRCA mutant, very good. You can give olaparib as maintenance. Even if it is HRD positive and BRCA wild type, you can give olaparib plus bevacizumab. So the decision of adding bevacizumab will be after the surgery. Why I'm saying after the surgery? If it is, a sandwich surgery, you give anterior chemotherapy and neoadjuvant chemotherapy. If you add bevacizumab there, then probably the surgery will get delayed, because you need a window of about 6 to 8 weeks before you can operate. These patients tend to bleed. So the best time would be you give anterior chemotherapy, you perform the surgery, and after that, if you find it is in the high risk category, which I told you, then you add bevacizumab. And after the completion of chemo, you can continue bev. If the patient is BRCA mutated or HRD positive, you can add PARP inhibitors. And when you add PARP inhibitors in that BRCA mutated patients, you find that 50% of patients are surviving after 5 years. So that is the magnitude of just taking a pill. Thank you.
Thank you very much, sir, for a nice and elaborative talk on PARP inhibitors. Now our